Welcome to our renal grant rounds. It's really my pleasure to introduce our guest speaker for today's renal grant rounds, Dr. Sandeep Mallipattu. So a few words for Dr. Mallipattu. He is the chief of the Division of Nephrology and Hypertension at Stony Brook, and he is the DCI-Liebowitz Endowed Professor of Medicine in the Renaissance School of Medicine at Stony Brook University. Dr. Mallipattu is really nationally and internationally recognized for his research on identified molecular mechanisms regulating the progression of chronic kidney disease. His research investigates mechanisms by which gene expression regulated by transcription factors called Krüppel-Like factors. They regulate very important fundamental cellular processes in the kidney. And the goal of his research is to identify new pathways that can be targeted for the urgently needed therapies. Dr. Mallipattu really has basically, been everywhere in the country. So he did his biomedical engineering bachelor studies at the University of California, San Diego. And then he earned his medical degree from Boston University. He moved then to East Coast, where he did his internal medicine and nephrology fellowship at the Mount Sinai School of Medicine. He has been really a star physician scientist, and this is, shown by his publication record, awards and recognitions. Just to mention, some major awards, really. The Presidential Early Career Award for Scientists and Engineers. This is the highest honor given by the US government to outstanding scientists and engineers at the outset of their independent research career. He's elected to the American Society of Clinical Investigation, even has a Young Physician Scientist Award from this society. And, the other award that tells a lot is the Stony Brook Medicine Faculty Mentoring Award in recognition of mentoring junior faculty and students. Now, in addition to having NIH, a VA Merit Award, Dr. Mallipattu somehow manages to direct, on top of that, the Long Island Network of Clinical and Translational Science Scholar Program for junior faculty engaged in clinical and translational research. He serves as a multi-PI of a multi-institutional NIH and NIDTK training program. And then he participates in study sections, editorial board memberships, international lectureships all over the world. And I will stop here and welcome Sandeep. Thank you so much for visiting us.
Thank you for the kind words and the invitation. I wish my wife could hear that introduction. So she gives me a hard time for everything. So, but thank you again for the invitation. It's a privilege to be here, and I've learned a lot about some of the research the faculty here in the division in the morning, and I think it's an exciting time to be here, and I'm hoping to touch on some stuff that, in the interest of time, not obviously everything, but at least focus on one story. And hopefully, that could lead to potential collaborations with some of you here. So let me just go through the disclosures, which I think is important. I do have a huge conflict here. One of the things we're going to be talking about is how we got to the story of developing small molecules, and we do have a patent on this composition of matter patent for these KL15 agonists. So I just need to disclose that in the beginning. So oftentimes, we run out of time at the end, and I think Penelope was kind of alluding to this, is I think it's really important to give credit to the folks that are doing the work. and especially those that have transitioned to different phases of their career, whether they're going to graduate school and MSTP programs, or they have career development awards and gone on to get their own independent funding. A couple of the folks the story we're going to try to focus on here. Yi-Ching has been a research scientist in my lab for the longest period of time, for about 7 years, and we're going to focus on some of the work he's done. Also, a couple of students that have really worked on it, which I'm going to go through, that have kind of gone through developing their own careers after they've finished their postdoctoral work as well. And a couple of folks here that really helped branch off into their own careers, Chelsea and Sean, who've had their career development awards and moved along, so, and the funding sources. So I want to briefly review the impact. I don't think this audience needs too much of an introduction on the impact of proteinuric diseases and the population here. I'd like to highlight the role of Krüppel-Like factors, and some of you may know about their biology because they're pretty diverse in their roles and what they've really focused on. And then also potentially, if we have time, to go over the central role of podocytes in mediating cell-to-cell communication in kidney health and disease. So I think we have some fellows I see in the audience. So I think it would be important to kind of go over at least a case presentation. So this is something I had when I was in early stages of my career, and patients that have seen that kind of could potentially recapitulate, and hopefully you can kind of find some common ground to this. So this first case, and it's not really a diagnostic dilemma. I just want to go over how we manage both these patients and what are potential areas of investigation we could focus on. This first case is, 52-year-old Hispanic male presented to the hospital with 1 week of vomiting, abdominal distension, bilateral lower extremity edema. Had a history of hypothyroidism, hypertensive, really clearly classically, it looks like he has nephrotic syndrome. His creatinine was 1.8, his serum albumin was low, and he had about 10 grams on the protein to creatinine ratio. He underwent a kidney biopsy and was identified to be a tip variant version of FSGS. He had mild to moderate interstitial fibrosis and tubular atrophy, but certainly diffuse foot process effacement. So really like a primary FSGS type phenotype. He received prednisone, actually. He got the 2 mg per kg, the Ponticelli regimen, and then every other day for about 10 months with a taper, and he did recover. His proteinuria improved, serum creatinine normalized to some degree. So here's a second case. This was an interesting case. So perhaps it can be, from the pediatric nephrology side, to address this as well. So 25-year-old male who presented to the hospital about 1 week of generalized malaise and increased lower extremity swelling. So what was interesting, about 10 years before, he had been diagnosed with FSGS at age of 15. He received 6 months of prednisone. Didn't really work, so it was steroid non-responsive. And then he received cyclosporin, a calcineurin inhibitor. And so for about a 3-year period, and his proteinuria improved, but due to loss of follow-up, he was about 18 years old, going to college, just stopped taking his meds. And then he presents almost now 10 years to the original presentation, which appears to be potentially a recurrence of his glomerular disease, or FSGS. So he was hypertensive, again, similar features of a nephrotic syndrome, and he had now worsening creatinine, and he had a lot of protein in the urine. So, and we rebiopsied him just to see whether is this a progression or there's a de novo lesion. So here you had 30% of his glomeruli was globally sclerosed. And 30% shows segmental sclerosis with adhesion, so a perihilar phenotype, not a tip variant that you had in the first case. Prior biopsy had about 25% sclerosis with very minimal global lesions. So you can see this is really a progression of his disease. And he had a bit more interstitial fibrosis, but also in this case, he had really diffuse foot process effacement as well. So in this case, he was originally non-responsive to prednisone in 2004, but responsive to cyclosporin for a few years after that. But he was lost to follow-up, and we restarted it in 2014, but really with really minimal improvement. So he had a little bit of improvement in protein to creatinine ratio, but his creatinine worsened. Eventually was started on dialysis. So you can see these 2 different cases that had presented: somebody that's steroid responsive, presumably another person that's not responsive. And as we all know, FSGS doesn't really tell us about necessarily the etiology of the disease, rather it's a histological diagnosis. But I want to just review the impact of proteinuric diseases, and we all know the impact of chronic kidney disease. But what's interesting from USRDS data, and this is before data captured before the pandemic. But you can see, regardless of the etiology, a significant proportion of individuals do have proteinuria, whether it's related to diabetes or hypertension or obesity, as I was talking to Dr. Lin earlier. And so because of this, we do know that albuminuria is incorporated into the staging of chronic kidney disease and has an impact on our clinical care. And this is data, what was interesting, I pulled from the Department of Human Health Services, but also from CDC, to show that the causes of death, inpatient causes of death in the hospital associations, and the top 10 is actually nephritis, nephrotic syndrome, and nephrosis. It may not be the direct etiology, but certainly patients that are more sick, or likelihood of association mortality does exist. So what do we know about podocytes? And again, this is going to be a brief review for a lot of you here, but I want to set the stage. Over the last 20 years, there's been a huge amount of literature and evidence to understand the biology, potential mechanisms of these cells that are terminally differentiated post-mitotic cells with really minimal capacity to regenerate. But while they have the minimal capacity to regenerate, they're highly dynamic in nature. They have the ability to hypertrophy. There are features of migration that occurs. And they are these exquisite cells. This is from a scanning electron microscopy view that shows really the interdigitating foot processes that really prevent the loss of macromolecules such as albumin into the urine. And we know the spectrum of podocyte diseases clinically. We know that are genetic in etiology, some that are environment contributing. We do know that over time with age, there are associations for progression of age-related insults to podocyte loss. And we also know that compared to having diffuse foot process effacement, a foot process effacement that you can get with minimal change disease versus something where you actually lose podocytes, really starts the scarring that occurs in the glomerulus. And so this process of identifying how can we repair before there's podocyte loss has been the question at hand for now, for over a decade. So I just want to touch briefly, it is not about going into directly all the treatments. Some of you are experts in this, really on managing patients. Oftentimes podocytopathies, if you looked at FSGS alone, perhaps, we tend to treat trying to identify if it's primary or secondary in origin. But you do want to treat if it's secondary, the underlying etiology, and you can go through initial conservative management if it is secondary, especially if it's obesity-related FSGS, such as secondary of weight loss. We often have everyone RAS blockade because we do know that it directly also affects the podocyte cytoskeleton. There's some data on use of SGLT2 inhibitors in FSGS, but as we know, that the data is more clear on IgA nephropathy. Certainly salt, restricted diet, high protein, reducing the amount of protein. But still, the primary FSGS, the mainstay has been for a long time glucocorticoids. And how do we minimize the sparing use of these or identify individuals that would benefit from high-dose prednisone and a taper? Second, we do have calcineurin inhibitors where there's good data to understand that this could potentially reduce the amount of steroid dose that's needed, or those that are non-responsive, some towards MMF, certainly a little bit of data towards rituximab. And now it's an exciting time, especially with the FDA has really allowed the use of proteinuria as a surrogate endpoint for clinical trials, is that now with the use of inhibiting with inaxaplin for ApoL1 individuals with the variant, as well as baricitinib for JAK1, JAK2 inhibitors. Sparsentan, as you know, has gotten accelerated FDA approval for IgA nephropathy. There's some data on FSGS. There was an improvement in GFR, but certainly a reduction in proteinuria. There's some data. It's a bit equivocal in terms of using coenzyme Q10, looking at restoring mitochondrial health in the podocytes, and as well as curcumin. And there's new trials underway in targeting TRPC6 as well, a complement to especially C5a. And there was a really nice review recently, just came out. So it's a good review to look at all these new trials that are recruiting patients targeting specific agents along the way. Now, I just want to take a step back, and I think the clinicians in the room know this, is the use of glucocorticoids in primary FSGS. It's actually one of the oldest data, but the evidence is actually really low for it, right? It's the grade 2C in the KDIGO guidelines, the original Ponticelli regimen, where it's 1 mg per kg per day. median duration, as the fellows, know when you start it, is 16 weeks of treatment. The remission rates, however, are highly variable. Here, the data here, looking at folks that also have a complete response to those that have a partial response. And the interesting thing is that we use this all the time, but it's based on a retrospective study of about 80 patients in the beginning. And the reason we picked 16 weeks is this original Ponticelli regimen that said less than 16 weeks, there's about a 15% complete remission. Greater than 16 weeks, you have a higher remission rate. So this is really the data that we have, and there's new studies trying to come out looking at this, but as you know, they're combination therapies to newer agents. And clinicians know the complications with high dose and chronic use of glucocorticoids, right? I don't have to tell you about sodium retention, hypertension, impaired glucose metabolism, diabetes, infections, bone disease. There's nice work coming from the NIH, from Jeff Gopp's groups, showing really the open label clinical trials of oral pulse dose dexamethasone and the complications that they're observed with the use in the idiopathic nephrotic syndrome. There are some data to show that there are variants to show in the glucocorticoid receptor, those that are likely to be susceptible to infections versus not. But the way I always think of it is that this is a bit of a shotgun approach that we're doing with using glucocorticoids, and it has some benefit and will always have a role in our in these podocytopathies. But nonetheless, can we try to identify downstream targets that would be of help? So what do we know about glucocorticoid therapy? We know about the immunomodulatory effects, but there's really old data, and I call it old now because now it's in the early 2000s, but when we're talking about it, it was kind of newish data back then, but to show that the glucocorticoid receptor does exist in the podocytes. And so just briefly, the biochemistry, right? So we know glucocorticoids or corticosteroids bind to the glucocorticoid receptor that resides in the cytoplasm. They homodimerize and they translocate to the nucleus to regulate gene expression. So it acts as a transcription factor, right? The glucocorticoid receptor. So here's some data that's been shown now that from previously and from a couple of groups, that treatment with dexamethasone in podocytes, you get translocation of the glucocorticoid receptor from the cytoplasm to the nucleus. I'm going to try to minimize the Western blots as much as possible because I know it's lunch and I don't want anyone to have whiplash injury by falling asleep. So, but this also shows that nuclear localization occurs of GR directly into the nucleus. And folks such as Stuart Shanklin and coming out from pediatric groups as well, showing that there's treatment with dexamethasone preserves the actin cytoskeleton in podocytes in the setting of puromycin treatment, where there's toxicity that occurs. It's been shown to increase phosphorylation of nephrin. And this is work from Yale showing that where they knocked out the glucocorticoid receptor in podocytes to show, and using an LPS model, nonetheless, to showing that there was an exacerbation of proteinuria. So there's some data to show that there's a role for potential direct targeted role for glucocorticoids in podocytes. So based on this, one of the things when I was a fellow really in the lab, after my clinical training, to understand, well, how do glucocorticoids work? So is there a way we can identify downstream targets that we can use to study and maybe minimize some of the off-target effects, right? So there's some data, actually, it's interesting. And if you look at airway smooth muscle cells, patients with underlying airway diseases where they use steroids pretty frequently, as you know, the pulmonologists, there was data taking that if you take airway smooth muscle cells and treat with dexamethasone, and this is really old data where they weren't doing RNA-seq, they were doing microarray. And so to show that what genes are expressed really early within 4 hours and what remain elevated at 24 hours. And so some of these are classic canonical glucocorticoid responsive genes like FKBP5, FOXO1, and some of this PRE1 as well. But what really stood out, at least when I was reviewing this paper, was this gene called KLF15. And it's induced really early within 4 hours. And this is validation by qPCR in black, and this is by array, and it remains elevated as well. So it was induced really early in these airway smooth muscle cells. And in this paper, which was kind of interesting, they showed that when you overexpress it, it actually inhibited proliferation of airway smooth muscle cells. So kind of preserves some of the potential differentiation properties of the cell. So what are Krüppel-Like factors, right? And so when you look at the literature for this, it's really started the identification of Krüppel, the gene, was in fruit flies in the early 1950s. It was actually identified by a German scientist. So the word Krüppel, and I'm in part mispronouncing it, but Krüppel means the word cripple. So when you mutate or knock this out in fruit flies, they die of the embryonic lethality occurs due to body segmentation defects. And so from what I understand, there are Germans in the room, it's meant as a very derogatory word, Krüppel. So what there are mutations in the fruit fly, Drosophila, but in the mammalian genome, there's orthologs for Krüppels. There's actually 17 members. So this is a review that we wrote some time ago, but you can look, there's 17 members. There's remarkable homology in the C-terminal end. This is where, as a transcription factor, is going to bind to genes and regulate downstream pathways. And so it has these cysteine, histidine residues, 3 of them in the C-terminal, and a lot of the heterogeneity exists in the N-terminal end. So that's where the regulation occurs of the gene. And some of these, there's certainly redundancy within certain cell types, and there are others that are really restricted to specific cell types throughout the body. So what are they involved in, right? I think the bigger question is like, what are they not involved in? They're involved in almost, if you look through the literature, involved in methylation, apoptosis. Classically, we know about KLF4, which is the Yamanaka factor, right? One of the four Yamanaka factors that are involved in inducing pluripotency. And so that's been well studied, and a lot of this, the literature has gone into that. And if you look through the publications, if you just PubMed it, this is data that brought out right around before the COVID pandemic. And so, but you could look at the number of citations per year has risen over time. A lot of the work is in cancer biology, but we focus in the kidney, but folks have looked at in cardiovascular diseases, and neuronal disorders, intestinal disorders, as well as hematopoietic disorders as well. So it's really well studied and characterized over time. And so our lab over time, our group has expanded, and where we're looking, studying the role of Krüppel-Like factors in various processes. I don't think we'll have time to get into the details. So some of the things I wanted to hopefully touch on in the future, we could look at is to their role in really cell metabolism. We've looked at to see how KL15 actually works together with PPAR alpha in regulating expression of fatty acid oxidation. Same thing as looking at the role of KL6 in amino acid metabolism in the proximal tubule. And we looked at potential cellular crosstalk as well between the podocytes and neighboring periepithelial cells and proximal tubules. One area I wanted to really focus on is this role of, where we start with KL15, a potentially glucocorticoid responsive gene. And this is work I started when I was a fellow, when I was at Sinai. And, fortunately, my mentor at that time, John, he allowed me to take that work as I transitioned to Stony Brook to build off of it. And so what do we know about Krüppel-Like factor 15 or KLF15? So the other name for it was KKLF because it's originally identified in the kidney. It was cloned in the kidney, and the name was kidney-enriched KLF. It's actually critical also for nephrocytes. These are the model cells for podocytes and fruit flies. So if you knock it out specifically in these cells, there's development issues and differentiation in Drosophila. So while it's expressed in the kidney, it's actually fairly promiscuous. It's expressed in a lot of different cell types, epithelial cells. There's a host of literature studying and really high impact journals studying its role in cardiovascular disease, cardiac hypertrophy, also a role in circadian biology as well. And what we know about work from Matthias Kretschler's group is that KLF binding sites reside in some of the canonical podocyte-specific genes from their promoter analysis that I did some years ago. And when we knock out KL15, it increases the susceptibility to proteinuric diseases. And this is work that's been published. And also when I was in the lab, John, he at the time was studying retinoic acid. For a period of time in the beginning, they thought maybe retinoic acid could be used for some of the podocytopathies before they addressed the cytotoxicities associated with it. But what we showed is that the effects of retinoic acid are Krebs dependent and are mediated through KL15. So when we knock out KL15, the effects of retinoic acid are mitigated. And that's universal in cells that express KL15. And we've shown that the expression is reduced in some of the glomerular diseases such as primary FSGS and HIV-associated nephropathy from kidney biopsy specimens. So we went on to show, at least this paper from a few years ago, is that glucocorticoid receptor regulates KL15 in the podocytes. So treatment with dexamethasone increases its expression by immunostaining as well by Western, which was in the paper. And then we went on to show that when we treat with dexamethasone, glucocorticoid receptor as a transcription factor binds to the promoter of KL15 and allows its expression to increase. So this is just chromatin immunoprecipitation showing the induction. And then this is a luciferase reporter. So the way this works is that you take the promoter of KL15 and you tag it to a luciferase. So if anything that turns on the promoter, it's going to light up. And so we mutated the region where glucocorticoid receptor should sit. And you could see when you do that, there's attenuation of it. But then when you just treat with dexamethasone with the wild type reporter, it's going to increase. We went on to also show in a couple of different models, this is using an antiglomerular antibody, a little different than what David Salon's nephrotoxic serum. This is from Stuart Shanklin, antiglomerular antibody. And so that targets, and there's lesions of FSGS that develop in these mice. And so when we knocked out KL15 only in the podocytes using this Krüppel-Like system, you get this improvement in proteinuria in the setting of DEX. So what happened was if you in the wild type mice, you get an improvement. So here you could see we treated with the antiglomerular antibody, and then we treat with dexamethasone every 48 hours, trying to model what we would do clinically. So in the wild type mice, you get an improvement in sclerotic lesions as well as proteinuria, but in the knockout mice, this is lost. And so what was interesting is that if you take the collected serum and look at all the inflammatory markers, they're very similar between the wild type mice and the knockout. And so at least the hypothesis that we speculated from this is that the potential effects of glucocorticoids could be direct to the podocyte mediated through KL15, because when you knock it out in podocytes, the effects were mitigated. We went on to show from kidney biopsy specimens. So we collected this from at Sinai as well as Stony Brook. And we looked at patients that received glucocorticoids diagnosed with either minimal change disease and FSGS. And we stained for KL15 as well as co-stained it with the Wilms tumor 1, a podocyte marker, because the reviewers wanted us to tell us whether this is specifically changes in the podocytes, but to show that somebody who responded had a relative preservation of KL15 expression versus those that did not respond. So at least here we tried to suggest, or the data suggested, that the lack of responsiveness to steroids was associated with a reduced expression of, or podocyte expression of KL15. So we have these potential global approaches. So what about genetically targeting KL15? It is a transcription factor. I was speaking to some of you earlier this morning about when you target a transcription factor, it could have all these off-target effects because it's going to turn on genes, turn off genes. So what would happen here, right? But we wanted to test it. So what we did this is work from Yu Cheng. So you can't see these two bars, but what we use is this HIV-1 transgenic mouse model. So some of you may have worked with this model, but this is the classic TG26 model, and it was developed in the early 80s. So these mice, they express the HIV transgene, but they have the virulent genes such as the GAG and POL deleted. So the transgene is expressed throughout the epithelium in the kidney, and these mice develop really massive proteinuria starting at 4 weeks of age, and they progress to kidney disease, and about half the mice die about 12 to 14 weeks of age. So you get this progression from collapsing lesions all the way to tubular interstitial disease and atrophy. So what we did, the first two, we overexpressed or induced expression of human KL15 in podocytes only. And this is this model where we can turn on the expression using doxycycline, a tetracycline inducible system. And then this lighter gray is just the TG26 mice. So here, the lighter gray of these mice, starting at 4 weeks of age, their proteinuria continues to increase. So this is if you guys have done ELISA for this, it's actually milligrams for milligrams. So this is actually a lot of albuminuria that occurs in this model. It's very reproducible, folks that have it, and you want to use the hemizygous TG26 mice. And then when we turn on KL15 around 4 weeks of age, so about after they've already developed proteinuria, you can see the resolution of the proteinuria that occurs or albuminuria that occurs just with induction of KL15 only in podocytes. What was interesting is also there was an improvement in kidney function with the induction of KL15. And also about, like I said, these mice die, 50% die by about 12 to 14 weeks of age. And then just with induction of KL15, there was a preservation in overall mice survival as well. And, the paper, if anyone's interested, look at the details, but quantifications and so forth. I just want to show some representative images from this that were scored by 2 pathologists and Dr. DeGatti as well as Dr. Ravello, and to show that here you can see this protein cast in these TG26 mice with interstitial inflammation and also sclerotic lesions that develop. And then with induction of KL15, it's fairly preserved. And this is a large number of animals, not like N equals 4. So we actually had a large set to demonstrate this. And so we went on to show in that paper, well, what are potential ways what is a mechanism for the protective phenotype? What we showed is that at that time we did bulk RNA-seq and isolated glomerular fractions, and you could see the genes that were turned on and turned off and which had KL15 binding sites. A lot of the genes that had KL15 binding sites were classic podocyte genes, like some of the fellows would have to know for their boards, like NPHS1 or WT1, where mutations in these genes are associated with congenital nephrotic syndromes. And what we showed is that some of these genes, especially WT1, was also that it was increased in expression. KL15 had binding sites in a lot of these genes. So we went on to show here, I just wanted to show the schematic, is what we went on to show is that when KL15 regulates, a lot of the host genes are mediated through WT1. So when we knock out WT1 and induce KL15, it doesn't really improve the cell survival. So when you knock out WT1, this is old data, and we reproduced it from publications in podocytes, the cells die. It's really required for podocyte differentiation. When we overexpress KL15, you don't get maybe some little restoration because you're not really regulating the key canonical pathways. However, if we knock out KL15, the cells also die, but when we induce WT1, you get some degree of restoration. So we believe that there's a feed-forward type circuit that occurs, that there are some downstream targets that are mediated to WT1, and some are directly through KL15. So from here, we looked at, well, what about pharmacological inducers of KL15? So very little is known about what are potential genes that can upregulate KL15. We know what dexamethasone does. It's early inducible because directly targets retinoic acid does. But can we identify potential small molecule agonists that can induce KL15 without potentially the off-target effects of these other agents? So this is work now, it's like 4 years in work that we spent time developing. And so what we first did was we developed this reporter assay. So we took human podocytes, and so these are differentiated human podocytes where they express this T antigen, and when we move them to 37 degrees, it degrades and the cells stop dividing. It's a common way of immortalizing these cells, and it's not perfect. They have issues, but they are a model system. So what we did was we took the KL15 reporter, again, tagged it to the luciferase, and then we screened a library of compounds. We wanted to start with something that's been validated that we can potentially use. So we contacted the NCI, and they have a library of the diversity set compounds. It's about a little over 2,500 compounds. It's not like 20,000. And we had positive controls. We know dexamethasone increases KL15 reporter activity or promoter activity, and same as retinoic acid. And we started screening them. So what we went on to show here is from the initial, we actually took some time to validate the assay that there was adequate signal to background ratio. And also the reproducibility was consistent among the patients. So that took about several months to a year. We initially got 44 hits that had greater than 2.5-fold in reporter activity. So this is all under the premise that when we induce KL15 expression, there was a protective phenotype. So we're trying to see, well, can we come up with small molecules that can induce it? And so our chemists or the drug development folks say that, well, you need to have molecules that are low in terms of the concentration required to induce activity. So this is EC50, or the minimal 50% required, 50% of the concentration required to induce, the concentration required to induce 50% of reporter activity. And so we see compounds that are less than 100 nanomolar. And then from our chemists, well, 3 of these are potentially druggable targets, or could be potential leads because they are the biochemistry is there for the likelihood as a viable small molecule. And so from these, we looked at these compounds that had a fairly low EC50 here. This is their nanomolar compared to dexamethasone, which is fairly high, but that's what we use, clinically, and as well as retinoic acid comparatively. We went on to show that when we mutate the glucocorticoid response element in the reporter, the effects of dexamethasone on inducing KL15 activity are mitigated, but these agents still induce reporter activity. So it's working independent of glucocorticoid signaling. So that was one of the goals. We wanted to identify molecules that are independent of it, so it could potentially combine with it long term. We went on to show these molecules also improved the reporter activity in the setting of Adriamycin treatment, which reduces KL15 activity. Let's see if I can use this pointer. Oh, yeah. And also we went on to show that the viability is maintained to some degree. So based on this, we said, well, can we improve the pharmacology of this compound? So can we make it more bioavailable and so forth? So we worked with our medicinal chemist, and we underwent a structure-activity relationship study. So this, using C7, we went on to identify the mode, and I'll go through the structure of the compound that we identified through this. And so we generated about 15 derivatives or analogs of that initial C7 compound from the hit that we got from the screen. And so we had about 3 compounds that had pretty good amount of reporter activity that was maintained. And what was really interesting we wanted to do here is that we knocked out KL15 in cells, and these compounds could not maintain cell survival, suggesting they're actually, we've been doing reporter activity, but this was the first test we're showing that these compounds could be working through KL15. So when we knock it out, the effects were mitigated. We went on to show that they had very low EC50 like 2 of these had lower EC50 compared to 502. So 503 was less than 10 nanomolar, and it was not toxic. So we decided to pursue that further. So what this is, it's a urea-based compound, and we went on to show, and so there are urea-based derivatives out there, but it hasn't really been studied in kidney disease as well. And so we went on quickly to see a transient model. It's not the best model, but we wanted to do a short term. And we see treatment with BT503 in the setting of lipopolysaccharide treatment has some restoration of albuminuria. And what was also interesting is that if you give dexamethasone, you get some induction of reporter activity. With BT503 alone, it was much higher. And then combination has potential synergism. So we're trying to work through this. This is all unpublished. Trying to see, can we do this, recapitulate this in the animal model? But in the cell culture, it looks like there could be maybe some combination treatments that we could use, or reduce the amount of dexamethasone that we need to improve podocyte health. We went on to show in a second model, because that was just a transient. LPS is not the best model to look at proteinuric diseases. So we did nephrotoxic serum. So this is using serum from Dr. David Salant. And so where he has this model where these mice target the podocytes, and they get lesions that are sclerotic, and you get this pretty high amount of proteinuria, and it tends to subside over time. So, but compared to LPS, it's not, you do get sclerotic lesions. BT503 had some restoration in the amount of proteinuria, and it's not complete. So it's not going to completely reverse any of the changes. There was some improvement in the proteinuria. We see amount of sclerotic lesions. Again, these are representative images, but you can see here in the whole section here, coronal section, that you can see the protein casts that are pretty prevalent throughout the NTS-treated mice compared to the BT503 treated mice. There's some improvement, but there's still amount of protein casts there. And so you get about 50% or so reduction in FSGS lesions. This is quantified by the pathologist. And then, so this was a second model. So we wanted to come with a third one that would potentially look to see something that's progressive. So we went back to our HIV-1 transgenic mice where the KL15 induction had protection. So again, what these mice are, and show two different pathways here. If you look on the right, so this is again a lot of proteinuria compared to the NTS or the LPS treated mice. They get proteinuria, and we started late because we wanted to make sure we weren't affecting any developmental changes with early induction or with treatment with a molecule, but also to see if there's a potential reversal. So in red here are these TG26 mice. So over time, for the most part, they progress. There's some they maintain the amount of proteinuria, but they progress in injury. Overall treatment with BT503, you can't see here, it's actually buried, but the amount of proteinuria is reduced or it does not increase as high. And this is to see a percent change that we're seeing. So some of these are just, when we did the calculation, these are exorbitantly high percent change because they start about 2 to 3 grams or 2 to 3 milligrams per milligram of proteinuria at 8 weeks, and they progress to pretty significant versus in the setting of the BT503 treatment. So you see an improvement in tubular interstitial injury as well as the sclerotic lesions. And also what's important here compared to the other models where we couldn't do it, we can actually measure kidney function, which is, the gold standard at the end of the day. And we see an improvement in serum urea nitrogen as well as serum creatinine. And then here is to just show a little bit more of these coronal sections. You could see in the TD26 mice, overall using a Masson trichrome stain, the blue is bad, right? So is that they have a lot more interstitial fibrosis, which is somewhat improved here. Again, these are representative images of alpha SMA staining. So we had quantified these as well. We also have been trying to see, we're asked by the reviewers to see, is there potential to test in kidney organoids? So we've been working on trying to understand how we can model it. So we worked with Neil Hagridi's lab at Pittsburgh, where they have the suspension kidney organoid model. So for those of you who remember, these are quote unquote small miniature tissues of kidneys where it doesn't recapitulate completely adult kidneys, but there's some improvement certainly compared to cell culture. But as we were talking about this morning, that they do have areas of undifferentiated. But the cool part of this suspension kidney organoid model is that you can generate hundreds of organoids, at over a period of differentiation versus one organoid that you have to maintain over days and weeks to get. And so this is just a resolution here in the 6-well culture dish. You can see these white spots. You're visibly seeing these kidney organoids that we're seeing. So here we see BT503 treatment in the setting of injury. You get some improvement, but you can still see these areas of undifferentiated areas, but you do get an induction of some degree of KL15 and WT1 being a podocyte marker. So one of the things we're working on here is, can we figure out an objective way to measure it? So this is going to be treated throughout the organoid. So when we treat it for about a 24-hour period. So one thing that we've been improving is these oxygen using seahorse. We have a way of measuring single organoid, their cell respiration rate. Presumably in the setting of injury like adriamycin, you get a reduction in spare respiratory capacity. This is after giving a decoupler, FCCP, and you get some assessment of mitochondrial reserve. But with BT503 treatment, you see some degree of restoration. So this is stuff we're trying to work at, trying to identify how can we use kidney organoids as a model system that could be used to assay small molecules and their effectiveness. So the last part I want to spend and to really go over this is the final is to see, well, we have a molecule that induces KL15, but how does it work? So it's interesting, the more in the last few years working with trying to talk to industry, big thing they're looking at, well, how does it work? What's the mechanism of action? What are the off-target effects? Is this bad? So so we show in the animal models, we have some cytotoxicity studies. It's not at the doses that we're using, even at higher doses. but we wanted to really look to see, can we figure out a mechanism of action? This took us some time. And so I think we have some idea of it now. So what we did was first a simple RNA-seq, not single cell, right? So we took podocytes in culture, treated with LPS and with BT503. So we see, again, this is not to look at individual age, general change in differentially expressed genes between LPS treated settings, DMSO versus 503. And what was striking, again, we have the details of this, is that differential genes involved, whether they're up or down, were highly involved in the NF-kappa B signaling pathway. So you can say, well, it's pro-inflammatory, what's there? But with BT503 treatment, there was a general suppression of NF-kappa B signaling. What was super interesting is that you can look at some of these canonical machinery involved in NF-kappa B signaling. So those of you that work on it, it's very complicated. But if you look at some of these genes, a lot of these are turned on, which is not surprising with lipopolysaccharide because it binds to the toll-like receptor 4, activates the cascade of signaling. But with BT503, some of these actually, there is a reduction in expression of these genes. So he said, well, could it be, and there's data to show that NF-kappa B actually suppresses KL15. So could it be that the molecule is working upstream and then we're seeing the readout of it below? So this is a schematic that we generated, but this is well known, right? And I just want to take a minute to show this. This is important. Any of you that work on NF-kappa B signaling as well. So when it gets activated, what you typically have are these NF-kappa B dimers, because there's a lot of NF-kappa B inhibitors out there, right, for cancer biology. A lot of them have not panned out because of the toxicity associated with it. Certainly hasn't been effective in the kidney. But so P50 and P65 are these NF-kappa B dimers. So they're tethered by this I-kappa beta alpha to the cytosol. They hang out there. And so in order for it to get activated, you need the machinery of the kinases. So you have this IKK beta and IKK alpha, and along with NEMO. So they come by here, especially IKK beta and alpha, they come and phosphorylate I-kappa beta. That allows for it to dissociate and gets ubiquinated and then gets degraded. And so when that happens, now P50, P65 hanging out in the cytoplasm can go right into the nucleus. And what's been shown, and we've shown that they actually transcriptionally suppress KL15 expression. So that's the general biology that's been shown before. And so what we did was first, again, I think the only last Western blot, so is to show here is when we treat with BT503 with LPS, you get an increase in the cytoplasmic cytoplasmic levels of I-kappa beta. And so that remains present here. So it's more. And what's interesting here is when you look at the cytoplasmic fraction, there's less of this P50 and P65, and there's more that gets translocated. I'm sorry, it's less in the setting of LPS because it's going in the setting of LPS, but with BT503 it remains in the cytoplasm, but less so in the nuclear fraction. So there's a lack of translocation. So it can't then regulate its pro-inflammatory levels. We see similarly KL15 in setting of BT503 expression is increased. And then these are just the housekeeping genes to show. So at least here is suggesting that BT503 inhibits nuclear translocation of the NF-kappa B dimers and restores nuclear KL15 levels. So, and then so then you're like, well, where is it targeting? There's all these kinases, right? So what we did was we looked back at our model system. So this is a really cool system because when you have podocytes in this undifferentiated state and we treat with BT503, there's no induction of KL15 activity. But then in the differentiated state is when you have an induction of KL15 activity. Why is that? So we then did simple RNA-seq to look at what are pathways so the target for BT503 must exist only in differentiated podocytes. So we looked at, well, what are these differentially expressed genes? And it looked like the number one pathway that perturbed in terms of transcription factors was NF-kappa B1. And then we actually show here, you have those two kinases, right? IKK alpha and IKK beta right here. So we look to see what is their expression in undifferentiated podocytes versus differentiated. And you could see here in the differentiated, there's just a general more expression. It doesn't go up in levels, but there's more and 37 versus 33, but not change for IKK alpha. What we went on to then do is work with our structural biologists and to model. So this is, if you haven't looked at it before, it could be confusing, but this green right here structure is BT503. So this is the urea derivatives right here, and they actually create hydrogen bonds. And I'm just showing you, just for complexity, these are the two protein residues that exist in the catalytic domain of IKK beta. So it actually forms these hydrogen bonds between there. So at least the folks that are documenting saying, well, this could bind there. We don't know yet, but modeling wise, it could bind there. What we then did was the following. So we have this kinase assay where we could look at the activity of IKK beta. So this black is a wild type IKK beta. And to show here that increasing concentration of BT503 reduces its activity. And the IC50 is not bad. It's 163 nanomolar. So the red here is interesting. It's a mutant in the ATP binding pocket of the kinase. So when we mutate it, this activity is lost, therefore suggesting that BT503 works at IKK beta. So this is kind of cool. At least now we kind of have a target. So what our hypothesis now is to show that potentially BT503 binds to IKK beta, preventing or inhibiting its kinase activity to allow it to phosphorylate I-kappa beta. So without that, it's P50, P65 stay in the cytoplasm and KL15 expression is maintained. So that's our working hypothesis that we have so far. And I think in the, we only have a few minutes. So I just want to say, potential role of KL15 agonists beyond podocytopathies, right? Talked about almost every study that they've done in cardiovascular, cardiac hypertrophy, when they knock it out, there are changes to cardiac hypertrophy, changes to heart failure that occurs, or the myocardial function. So it doesn't seem like knockout has at least a detrimental effect in some of these model systems. There could be, at least from what's in the literature so far. And we've done stuff where we took the FOXT1 Cree that I was talking about earlier, we were talking about earlier, is to see when we knock it out in potential resident fibroblasts that you get, you get exacerbation of kidney fibrosis and appears to downstream regulate Wnt beta-catenin signaling. This is data, again, this is to show that when we knock out KL15 in proximal tubules, so this is using the Pepsi-K Cree mice from Dr. Volker-Haas at Vanderbilt. And so we see that when we knock it out, you get about a 50% reduction in KL15. So not the best Cree, but nonetheless, you get about 50% reduction. In the setting of ursodeoxycholic acid, you get an exacerbation in proximal tubular injury. So what this is lotus lectin staining in the proximal tubules. And the red here, if you can appreciate it, is keratin 20, a marker of injured proximal tubules. And you get an enhancement of this in the knockout. And so we went on to show here, and this is from independent folks, that editorial that they wrote, to show that potentially KL15 works together with PPAR alpha to regulate downstream critical genes involved in fatty acid transport. So it's downstream of what we've been talking about. And so regulating CPT1A, which allows fatty acids, long-chain fatty acids, to get inside the mitochondria, as well as ACAA2 that's involved in the oxidation of fatty acids. And it's interesting now, we have a grant trying to understand now with KL15, with these molecules, how can it work together? And, I think there's data from phenofibrate that you published on showing that, well, there's potential toxicity in the early phase. Maybe there's protection in the latter phases. And that's what we're kind of seeing. And it's still not mature, but in acute kidney injury models, you get this period that it may not be beneficial, but potentially later in the long term. And in combination with KL15, could that be enhanced? So I'm going to stop there because in the interest of time, I could talk about the other projects, but I'm going to stop there. So if anyone has questions.